Good evening and welcome to another edition of an evening of education related to all things new with COVID-19. I'd like to make a particular mention to my colleagues in the Federally Qualified Health Center environment who have joined tonight to help make this as impactful as possible. And of course, to the esteemed panel of brilliant scientists and physicians who have come together to help us in our attempt to disseminate as much information as is possible today. I don't want to take more time, but want to take a particular opportunity to thank Dr. David Rich of Mount Sinai Medical Center, the leader, the fearless leader who has gotten us to this point and will continue to do so. Without further ado, Dr. Rich, please welcome the.
Mrs. Sternberg, thank you so much. It's very, very kind thing for you to say. It's been a great partnership with you and the Refuah organization, and I want to compliment you and your organization for helping us, colleagues who care passionately about the community and about providing the best possible medical information, to be just able to speak to so many of you out there. And we think that's just a very valuable thing, and thank you all for coming and listening tonight. I'm very delighted that Mount Sinai colleagues and colleague from Northwell, I believe, as well, are going to be joining tonight. And I think we can all give some very important insights. We've been on a long journey together, one of sadness and suffering and death, and but also a lot of hope and a lot of improvements in care. And the what's happening now with patients who become ill with COVID in the fall and winter is a different story than what we saw in the spring. But part of that needs your help. You know, we have to partner together to make sure that we see people very early in disease, that we test, and that we take vulnerable individuals who test positive and consider whether they meet the criteria potentially for monoclonal antibodies at this time. And, if they need hospitalization, possibly convalescent plasma. I have to say that it's been disappointing as a therapy. Probably only about a third of it has relatively high concentrations of antibodies, but certainly, that's all we have until hyperimmune globulins or monoclonals are approved for during the hospitalization. But I'd also just want to say that besides that, and learning about anticoagulation and steroids and improved respiratory management, it's a different disease, but still a very deadly one. And certainly when we find vulnerable individuals, we want to make sure they're seen as soon as possible because the monoclonal therapies seem to be quite beneficial in preventing progression of disease. Now, there's a lot of information and misinformation in this world we live in about vaccines, but I'm delighted to hear that there's a vaccine expert, I believe from Mayo, on tonight, and I think that's remarkable that you'll have that input. And I just want to encourage everyone to understand that Mount Sinai, Northwell, Mayo, it doesn't matter who we are, we're all united in trying to find the best possible way of helping people overcome COVID. And there's no question in the mind of any respectable scientist in the nation or the world that vaccines are the answer to a very deadly disease, and that the minuscule risk of any vaccine is vastly outweighed by the horrendous risk of COVID and what it's meant. And we've seen this in our communities. There's been lost way too many people and had made way too many ill for long periods of time. So I want to end on a positive note and say that we see a light at the end of the tunnel. We started to vaccinate healthcare workers, and I'm hopeful in New York State that in February we'll be vaccinating people in the general population over 75 years of age, and then gradually coming down from there. And it's just if we hold on for a few more weeks with the social distancing and the mask wearing and avoiding large indoor gatherings or limiting them to immediate family, that we will be able to keep this curve under control, because it's very clear that keeping the curve under control is the most important thing linked to death rates in a community. So we should all work together to make sure that we just reduce that level of transmission until vaccines become an important factor. We're very much interested in doing research with the community to look at seroprevalence levels. But once again, there's no scientist that believes that even a community is heavily affected as the observant community in the New York area is not close to herd immunity. So I just wanted to get these thoughts out there. I realize that what I say is not something everyone would agree with, but I want you to know that it comes from a good place and that I'm telling you what I sincerely believe, and that I'm delighted that Dr. Bander is going to be co-hosting this with Connie Sternberg, who's been a fantastic partner. And I just want to wish everyone a very safe and healthy 2021, the secular year, but still a very important milestone because we start to see hope with vaccines. And I hope everyone will encourage everyone as soon as it's possible to be vaccinated. Thank you all so much. Have a wonderful evening learning and asking questions.
Thank you. So I think what's amazing is, and Dr. Rich said it, is we've done these lectures before, and I think every time we do it, the amount of information that we learn turns over a multitude of times. It's always completely different information that we have, and so that's why it's great that we have this opportunity to get back on and educate the community. Tonight, obviously, we thank Refuah for putting it together, but we now have a coalition of multiple FQHCs from all over our area, from New Square, from Flatbush, Williamsburg, Borough Park, Lakewood, and we talked about in KJ as well. So we really have good representation here, and we hope to kind of hit on the most timely topics that are going on. We'd like to cover through everything from vaccines to treatments, who should go to the hospital, get a little update on the virus itself, what we've learned in the last few months to weeks. But I'd first like to start by going over who's on our panel tonight. So we have with us from Mount Sinai, who's been on before, Dr. Larry DiFabrizio, professor of pulmonary and critical care. He's been at the forefront of Mount Sinai's response. Many of you recognize his name. We have Dr. Sean Liu, who is assistant professor of medical director of the COVID clinical trials unit at Mount Sinai. He's been involved in everything from the vaccine research to the antibody therapies, plasma, and the hyperimmune globulin, which we're developing now. We have Viviana Simon, who is the professor of microbiology and infectious disease, a leading researcher on virology, who really has her space in understanding how viruses work, develop, and figuring out how we fight them. And for outside of Mount Sinai, we have Dr. Geeta Lisker, pulmonary and critical care. She's in charge of the Northwell Crown program, which is a program which we'll hear about, which treats COVID patients at home. And we have on from a guest from Mayo, Robert Jacobson, professor of pediatrics, who heads up the immunization program for Mayo Clinic. So I hear a lot about how other states are handling vaccinations and questions about who should get vaccinated and when. So, I'd like to kind of start the panel discussing a little bit of background on the virus. Dr. Simon, is there anything you would like to, give us a little update on what we've learned new since we've been on these calls?
Yeah, so we are now a year into the pandemic, and we have worldwide over 86 million people infected, with around 21 million in the United States. So this virus is really spreading. It's an RNA virus, so each time it spreads and infects another person, it has a possibility of changing its genome. And this has attracted a lot of attention over the past weeks in the news, that there are different variants of the virus that might have more or less mutations and might have different properties. So there is a lot of attention that has come over the past weeks to the so-called UK variant, which has been now found in over 30 countries of the world. As recently as a couple of days ago, the first case of a person here in New York State with this UK variant has been identified. And the concern is that this variant carries a number of mutations that have the possibility of changing its behavior. Fortunately, it seems that this variant is not more pathogenic, not more deadly, but it seems to be more transmissible. So in the UK, a large number of new infections are caused by this variant. So we are still in the process of figuring out whether this is truly only driven by the viral properties of being more transmissible, or if there is also a component of human behavior, where people are just getting very tired of following social distancing recommendations. So we are doing at Mount Sinai, we have a very active surveillance program. So we are actively monitoring if the patients that come to Sinai carry variants that are similar or alike the UK variants. So far, we haven't found any. It's important to know that vaccines will work against those variants, because the vaccine is going to elicit immune responses to different regions of the spike protein. So the spike protein is like the Empire State Building. It's really big and large, and only the receptor binding domain, it makes the contact to the cell. So mutations in the receptor binding domain is one of the mutations that has raised the alarm of the UK variant. But the vaccine is going to mount immunity against all kind of, every floor of the Empire State Building, antibodies will be mounted. So our immune responses elicited by the vaccine will work because it's independent of a single mutation. So it's important to avoid and to flatten the curve as much as possible, because if the virus doesn't infect new people, it will not acquire more mutations. So the virus only mutates in people. So if we can limit the number of new infections, we will also limit the ability of the virus to change in response to our immune. It's a constant battle between the virus and our immune system. Fortunately, coronaviruses do not change as rapidly as influenza, for example. So, but it's definitely something we are very, very carefully monitoring at Mount Sinai.
So you don't think that the mutations in the virus really, in these variants, really pose a threat to everything we're doing in terms of vaccines or monoclonal antibodies?
So the vaccines, I'm very optimistic, will work. The monoclonal antibodies are very specific and target individual epitopes. And ongoing studies are looking at whether certain variants of the virus might be less susceptible to those antibodies, because the antibody targets only one specific part of the spike, often in the receptor binding domain. And there have been reports where it seems that the viral variants are not as responsive to those monoclonal antibodies as other variants. But the experimental work in the lab still needs to be done to really test. There is some emerging evidence suggesting that some of the monoclonals are not as efficient in neutralizing some of those variants.
That's interesting. So, I mean, you mentioned that it doesn't change. I think one question that everyone constantly asks is about the flu virus. I know Sean's on as well. What is the difference really between a coronavirus and a flu virus that you can explain to regular people? Why is it so different that the vaccine will work one time but not work?
So the coronavirus is 3 times larger than flu. They are both made of RNA, but the coronavirus is one single stretch of RNA, whereas the influenza virus has different segments that can mix and match. And that allows influenza to recombine in the most unpredicted ways and really switch codes very rapidly. Whereas coronaviruses only acquire 1 or 2 mutations every month it infects new people. So it's much slower in its ability to change. So influenza can change entire segments of its genetic makeup, of its blueprint, whereas corona only is one stretch. And it's also much bigger, so many of the mutations might not really have a relevance on with respect to replication or immune escape.
Is there any concern? I mean, in the Dr. Liu, in the winter months, we talk about this being flu season, and it's that the weather itself tends to get people to become more infected. Is there any concern of the weather in terms of flu and corona? Do the viruses behave differently in terms of how we get infected?
I think I don't know of any direct influence of temperature and weather on the virus, but I think that just the seasonal change in weather just affects people's behaviors, and that's the main drive of different infection rates and different different infection rates, in the sense of like even just holidays and people gathering more often. and that's the main driver, not the temperature itself.
Okay.
And a positive side effect of social distancing is that the current flu numbers in New York City are really, really down. So at Mount Sinai, generally we have hundreds of influenza cases. And this year we have exactly 5.
Wow. So
this is unseen.
That's really interesting, though, that I guess if it's not spreading, it works for the influenza virus as well.
Yeah. So
I think it would be interesting also to hear, one of the things that we've discussed on the earlier panels is that, the COVID epidemic and the disease itself is really split into 2 phases. There's this infectious phase where the virus is replicating, and then what we keep talking about is the inflammatory phase. And I was going to ask the panel, and I'll start back with you, Dr. Simon, because it's what is it have we learned new about inflammation and, for the public, cytokine storms where people are getting steroids? What is it about this virus that's so unique that's causing all this damage?
So it's a new virus. Our immune system has never seen it, and it seems to really elicit this very strong innate immune dysregulation. What are the truly underlying mechanisms we are still trying to understand? Sean, do you have more insight on that?
Yeah, we're still trying to figure out why certain people develop this dysregulation while others just can get away with just a cold. It's a very big mystery, and once that puzzle piece is solved, we can actually might find a way to prevent that from happening. It's a key question.
2 studies have looked at severe cases, and there seems to be such a thing as antibodies against interferon that seem to be linked to very severe cases. So those are pre-existing antibodies against interferon, one of our innate strongest defense molecules, that result in this massive cytokine storm and dysregulation that is seen in severe diseases. And the other genetic component that has been linked to severe outcomes is mutations in immune defense genes also. But that explains maybe half or less of the severe cases. So this is not going to help us manage patients.
No, but it would be interesting to see, and who's been at risk. I think we were all, both the people on the panel, the doctors, the heads of the FQHC, we've all kind of struggled with exactly what Dr. Luce says, which is, we get 90-year-old patients who, show up with 2880 or we call high titer antibodies, and they maybe had a spike. We've had people who are 20-year-olds who are going to end up intubated in the ICU with difficult courses, and I think got pre-existing conditions. So that, that is the $1 million question, and we're not close to answering it yet. So, Dr. Lisker, any insights from what you've seen in the last wave? I know there's been difference, Dr. Reichman, that there's been differences now between the first and the second wave. I'm curious what you've observed in terms of people who are getting sick.
Hi, thanks. I don't think that there's been a very significant difference in the virus or in the disease itself. I think the difference has come because we have learned more about how to treat it. So I think, there was a very well-known study that came out at the summer, right, about the decreasing hospital mortality rates and even in decreasing hospital admissions. I think it's a lot more about us using steroids early on, using anticoagulation early on. I think a lot of what we learned about the virus has prevented people from getting worse. But there are still, unfortunately, plenty of people who are getting just as sick and going just as much into ARDS and clotting just as much as they were. I just think that we've gone back, number one, to the basics in the hospital, to the basics of critical care, and to the basics of using things like high flow nasal cannula, non-invasive ventilation, regular, ARDS or lung injury ventilation strategies, early use of steroids in the hospitalization patients. And I think that has improved our mortality. I think also the fact that, at least up to this point, we've been better staffed. We've had time to breathe. We've not been so inundated, the hospital, like it was, all the health systems in the spring, where we just got totally overwhelmed and you had people taking care of patients in the ICUs who weren't used to taking patients in the ICUs. I just hope it, unfortunately, it looks like it's about to head that way again. And so that's why my reiteration is to everyone, to please follow the rules on the outside so that we spare our health systems. But I'm sure Sinai is no different. I know at Northwell, I know speaking to my friends at other institutions, we're running 4 ICUs again. We're bringing in staff. We're deploying people who are not typical critical care physicians. So I hope it stays on the good path that we've been, but a lot of that was dependent on the fact that the numbers were reasonable and we were able to handle them. That's on the inpatient side for sure.
Yeah. But saying, I think that you make a good point in that that we are better prepared as a medical community to deal with it, and that's why we're seeing less of this chaos that we did the first time, or is there something different about the virus itself? I ask Dr. DiFabrizio, you've probably seen just as many patients as all of us here, not more. What are your thoughts? Is there anything different right now about how patients?
Well, I think that one of the main differences is the intensity of the kinds of patients that appeared at the hospital. Initially, we took the approach that you shouldn't come to the hospital unless you were very, very sick. We were testing patients who had very significant symptoms. So now we're diagnosing patients at earlier stages and also earlier in the course of the disease with much lower severity at the onset of medical intervention. So it was kind of shocking to me that, we would have 25% of patients who were tested requiring hospitalizations. And then among patients who were hospitalized, we had up to a 20% mortality. And in our ICU, if you were on a ventilator for a week, you had a 60% mortality. We're doing much, much better with those kinds of things because of many of the things that were already discussed. We have better treatment options. We are better staffed. And, I think that many of the therapies that we're providing has altered the course of the illness. So I think less of a burden of disease now as compared to before in terms of stress on the healthcare system and, significantly important treatment options, particularly with respect to the anti-inflammatory therapies and anticoagulation therapies. And I'm very, very hopeful about the monoclonal antibodies. And clearly that in the early phases where we have more of a viremic disease, therapies directed directly to the virus like remdesivir and monoclonal antibodies are going to have a big effect. What we're seeing a lot of now is patients in the critical care area who are late in their illness, 10 to 14 days after symptom onset, who now are in an inflammatory phase. And those types of patients, are very hard to delineate ahead of time who's going to do well and who's not. Unfortunately, we are seeing people who, despite our best efforts, are not responding. And those go on to develop severe lung injury, fibrosis, and sometimes even death. Fortunately, it's a quarter of what it used to be in terms of our mortality. So we've gone from a 20% in hospital mortality down to 5%. I think that's remarkable. And I think that we need to be able to be flexible and see patients early on in their illness so that some of these interventions, particularly with the monoclonal antibody, will be provided to them so that we may actually be able to alter the disease course. I think we are limited once we've exhausted anticoagulation and anti-inflammatory therapies for patients who are later in the course. We don't have great salvage therapies, once those have been exhausted.
Yeah.
So I'd say getting the patients evaluated early is the key, I think, to making another dent in this thing.
Yeah, I think it's interesting that we, from my observations and, the phenotype though does seem, I know that both you and Dr. Lister seem to think this is, all related to our response, the volume of patients, but, the phenotype sometimes seems to be different. I mean, the first wave, we had patients coming in renal failure.
Larry, it's David Rich. I just wanted to update a couple of numbers. Certainly over the summer, the mortality had come down from 20% to 5%. But with the larger burden of illness in the fall, we have seen it stabilize around 9%.
Yeah.
in the past several months. And it's interestingly, many fewer get intubated. The ones that get intubated now still have a high mortality rate, but it seems that requiring intubation is probably, is the deciding factor because they've reached a certain level of lack of responsiveness, as you said. But I wanted to endorse very much everything you said, just with a couple of corrections, because I didn't want to give an impression of a mortality rate that's lower than it actually is. But we are hopeful that with improved therapies, exactly as Dr. Lisker described, and you, Dr. Fabrizio, and Dr. Liu, and the incredible scientific comments I've heard from Dr. Simon, I think that we should focus on the fact that things have gotten better, and that's great.
Right, and I'm certainly hopeful that they're going to continue to improve. But you're absolutely right. When the patients get to a stage where they do require mechanical ventilation, and we've been very conservative here at Mount Sinai in terms of withholding mechanical ventilation. At other institutions, they don't use as much high flow or non-invasive ventilation. Sadly, if you were late in the course and you haven't responded, your mortality is pretty much the same as it was in the early phases, should you require that. And, I think it's never a good thing to be a non-responder. But I do think that it's probably 3-to-1 now in terms of people who are really in severe hypoxic respiratory failure, requiring mechanical ventilation, as opposed to early on when the recommendation was to place all these patients on respirators. So I think in our current ICU, we have, maybe a third of the number of people intubated that we had previously. So I think that, speaks to the fact that we're doing a better job, and also we're selecting people more carefully. Sadly, if you wind up on a ventilator, it's going to be a rough road.
Yeah, I mean, so I'll ask, I know, Dr. Lister, you're mostly in the doing the outpatient programs now, but what's been Northwell's experience? I would say I agree with Dr. DiFabrizio that we've avoided the ventilator as much as possible, and those who get it are in big trouble by us. So what's been Northwell's sort of experience now?
I would agree. I think it's about the same. I think we are we're back to using high flow as much as possible. We have many patients that come in and come in and out of the ICUs. They may be sitting on maximum high flow oxygen for quite a few days, but if at all possible, if they need to be intubated, okay, but we are managing them on high flow oxygen now, which unfortunately, the first couple of months of this, the directive was no high flow, non-invasive, and I think that led to a lot of unnecessary intubations and probably a lot of excess mortality. I think the same thing using these other non-invasive therapies. But those who fail those and do go on to be intubated at this point are still faring quite poorly. So I agree. I think that line that if you need to get intubated after that point, it's not good.
Great. So I'd like to, we're going to kind of come back and circle back to treatments and outpatients, who should be admitted, who should not. But I kind of wanted to focus a little bit because of its, the importance right now. New York State vaccines right now are just being administered to healthcare workers. I'll say we all as healthcare workers were pretty excited. I got my vaccine about 10 days ago. Despite seeing over 300 patients with COVID this wave since Rosh Hashanah, I don't have any antibodies since I'm lucky, thank God. PPE works for me, but I'm really glad I got the vaccine. New York State's not vaccinating patients yet, and hopefully soon. But I think that it's important that we start to talk about vaccines, who should get it. And Dr. Jacobson is on. Really glad he's on. Maybe you can give us a little bit of brief overview where we are with the vaccines, and what your thoughts are on who should get it prioritized. I don't know if we lost Dr. Jacobson.
There, I'm there. Sorry about that. You should be able to hear me now.
Yep.
No? You
Yes,
can?
go ahead. We hear
Okay,
you.
good. We have really good news in that we have 2 vaccines now that have received the Food and Drug Administration emergency use authorization, the Pfizer-BioNTech vaccine and the Moderna vaccine. These are both mRNA vaccines that have a wealth of clinical data behind them that support them as being efficacious against symptomatic COVID-19 disease, and have been shown to be safe. Of course, we have over 360 million to vaccinate in this country. Both these vaccines require 2 doses to achieve immunity, and each company is poised at this point to deliver in the first year about 100 million doses, with hopes that they might be able to expand production. So we have issues with limitation in terms of allocation initially. I want to talk a little bit first about what these vaccines are and what the emergency use authorization is. As physicians, we need to be confident with our colleagues and with our patients to be able to make strong recommendations. So, and to be able to make a strong recommendation for a vaccine, we need to know that they're effective, that they're safe, that they're needed, and that there's no alternatives. The epidemic and the epidemiology behind the epidemic show that the vaccines are needed. All of our effort with testing, screening, case tracking, masking, social distancing, all has been important, but hasn't controlled the waves of disease. So the need is there. While the emergency use authorization cut red tape at the licensure level, the FDA never let up in its requirements that companies who wanted achieve emergency use rapid authorization during this pandemic of their vaccines, they had to show 50% efficacy, safety data in more than 3,000 recipients, and indeed, both of these vaccines have achieved about 95% efficacy against symptomatic COVID-19 disease, and a remarkable safety record in randomized controlled trials comparing tens of thousands of patients who received the vaccine against those who got placebos, no increased signals in serious adverse events. Now, the emergency use authorization required 2 months of safety data for each dose. That's based on our understanding with previous vaccines that the safety signals that did occurred in the first weeks after the dose. The 2 months actually gives a very nice expanded coverage for the safety signals. Obviously, the work is not done. We'll have ongoing studies for long-term safety signals, just as we do with other licensed vaccines through the various vaccine safety data link system that engages about 15% of U.S. residents, linking their vaccine records with their medical records. The vaccine adverse events reporting system that requires providers and manufacturers to report certain side effects and reactions, as well as allows anyone else to report adverse events. In fact, the CDC and the FDA have rolled out a vaccine safe or V-safe program that allows for the voluntary collection of adverse events. So go ahead, please.
No, I was going to say was that I think, and I'm going to ask the panel the same thing. I think the biggest thing that people will ask, and, we'll go through some of the hesitancies people have, is, these mRNA vaccines are a completely new technology, correct? They've never been used before, in therapeutics. So yes, there is some safety data on the early things, but how do we know that this is not causing harm years from now, that we're not going to find out something later? I think that's people want to know.
It's an important question, and I'm glad you asked it. mRNA technology for producing a vaccine has been under study for decades. The big limitations with it early on was that once injected, the body so rapidly digested the mRNA that it produced very little protein to make immunity. There was about 2005, the technology advanced to the point where you could synthetically create an mRNA and then manipulate it a little bit so it would persist in the cytoplasm of the human cells just a little bit longer to make enough protein to make an immune response before the body got rid of it completely. We're talking about going from lasting in the body for minutes to lasting for hours or days. So the issue with the mRNA vaccines has been that the body just got rid of it so quickly. The lipid nanoparticles, the tiny little fat lipid membranes that cover the mRNA in these vaccines, is also a marvelous development in recent years that allows the mRNA to get into more cells so that it's actually lasting hours and surviving that rapid digestion so that the mRNA is at least there to make enough protein before it disappears. This mRNA does not get into the nucleus of the cells. It does not change the genetics of the human DNA. And as again, if anything, the body is rapidly getting rid of it rather than permitting it to combine with the DNA or persist. All of that is very reassuring. In fact, it was the mRNA technology, the companies that were developing it were initially developing it for other coronaviruses, SARS and MERS. And in fact, Pfizer, the BioNTech company that combined with Pfizer to make one of the vaccines that now has emergency use authorization, actually had the ability to rapidly move from what it had accomplished with SARS to make this vaccine for COVID-19 relatively rapidly. Unlike influenza, this is not a live viral vaccine. It doesn't have to be grown in cells, doesn't have to be grown in chick eggs. So that allowed for sort of rapid development and ability to make millions of doses of vaccine rather than depend on processes of past technology that would have really delayed this.
So you're saying the technology was just ripe for the moment, that we needed this sort of new technology to develop this.
Yes.
Dr. Liu, Dr. Simon, any specific concerns that we can address? I know that people talk about fears of, sterilization. I don't know where that came into the media from, but maybe anyone have any comments on what we have to worry about?
We've run some of the clinical studies here at Mount Sinai, and what you have to be aware of is that you will experience about 50% of people will experience side effects in terms of vaccine reactogenicity, meaning that after you receive your immunization, you will feel fevers, chills, headaches, arm pain, maybe some nausea, maybe some diarrhea after about 24 to 48 hours after you've received your injection. And that's about the extent of the main side effects. And people should be aware that those are normal and expected.
Is there a difference between types of vaccines that we have available?
The big differences between the vaccines, one has to do with storage and distribution. The Pfizer-BioNTech vaccine requires storage at negative 70 degrees Celsius, which really requires liquid nitrogen devices and containers, types of refrigerators that most clinical units don't have. This has really made it a bit more difficult to roll out the vaccine in rural areas and in areas away from academic centers. The Moderna vaccines freezing requirements are really only at negative 20 degrees Celsius, typical of the freezers that we're currently using in clinical settings for our frozen vaccines. The second big difference is that the Pfizer vaccine was studied at 21 days apart, whereas the Moderna vaccine was studied at 28 days apart. And while they're both mRNA vaccines that generate protein in the cytoplasm that is a spike glycoprotein fragment, from the COVID-19. We don't know if you could get one Pfizer vaccine and one Moderna vaccine and still get the same efficacy of 95% protection. And so I would, we really want to make sure that our patients who started with the Pfizer-BioNTech vaccine finish with the Pfizer-BioNTech vaccine, and same with the Moderna vaccines.
That's interesting. So if you start with one, you should be getting the same one dose. You wouldn't switch around between Pfizer, and that's important because some people have gotten it. Some people have traveled down to Florida to get vaccinated early who've been in rush. So I guess that's a really important piece of information. Now, there are many other vaccines now in development, from the adenovirus to there's I think 44 vaccines.
As of this morning, I counted 7 vaccines that have been authorized by one country or another and are currently in use, and another 55 that are in development, which is really exciting in a sense, because we may be able to solve problems with these newer vaccines that we aren't able to address with the Pfizer or Moderna vaccine. We may have modalities that will help in certain situations. Some are only in what we call preclinical phases, being studied at the lab bench or in animals. But I think a good 33 of them are in some form of a human trial right now, either phase 1 studies or phase 1/2 studies, or 2 or 3.
So Dr. Liu, who should not get the vaccine right now?
That's a very good question. There is limited data for certain populations, such as young children and pregnant women, but that has not been stopping the recommendation to give it in terms of having a discussion about the risks and benefits of receiving the vaccine versus the risks of actually getting COVID-19. So certain populations should have a discussion with their primary care provider before receiving the vaccine, and then specifically people with a history of severe allergic reactions to vaccines should also have a very thorough discussion with their provider as well before receiving the vaccine. Because there have been some people who have allergic reactions, and they tend to have a history of allergic reactions to different vaccines, and that's a discussion that should be had before getting it.
I would want to add to Dr. Liu's comments that there is one group that shouldn't get the vaccine, and that is a group who has a severe allergic reaction to a component of the vaccine or a previous dose of the vaccine. Now, we're talking anaphylaxis. We're talking about laryngospasm or respiratory distress, and not just hives following a dose of the Pfizer or Moderna vaccine. But that group is contraindicated in getting that second dose. Those who have had severe allergic or anaphylactic reactions to injectable drugs should discuss the benefit risk, their personal risk for getting COVID-19. If they're in a situation such as a healthcare worker, essential worker, they can't avoid exposure. They've got to weigh the fact that they can't protect themselves against COVID-19 as well as they could if they got the vaccine. So what we're doing for those with serious allergic reactions to injectable drugs and other vaccines is to have them remain in the vaccination site for 30 minutes for observation. And we're actually making a gentle suggestion to those who have had serious allergic reactions to non-injectable allergens such as shellfish or peanuts or eggs. Now, Dr. Liu brought up the issue of pregnancy. Both clinical trials, the phase 3 trials that led to the FDA authorization, excluded pregnant women and lactating women on purpose. So we don't have direct data regarding the efficacy or safety in these groups. But again, COVID-19 for a person who's at risk for exposure is incredibly hard on a pregnant person. They have 5 times the risk of complications. And given that healthcare workers or essential workers who are pregnant may need this protection, we again encourage that discussion with their healthcare provider. Consider the risks and benefits. Know that this is not a live viral vaccine. It's an mRNA vaccine that is only handled locally and very quickly in a matter of hours in the vaccination site, doesn't generalize to the rest of the body. Our U.S. Food and Drug Administration and our experts at the Advisory Committee on Immunization Practices took a very different tactic than the United Kingdom did and said for pregnant women, it's a precaution, but not a contraindication. It is something that should lead to discussion with your provider, shared decision-making, a weighing of the benefits and risks, rather than an absolute no. For lactating women, same issue. No direct data, but no theoretical basis for a concern. The US FDA and ACIP has said, have that discussion, consider your risks and benefits. Now, we are in a problem with the ages. The Pfizer vaccine was studied in those 16 years and older. We don't have data in children. The Moderna vaccine in 18 years and older. And the US FDA and the ACIP have for these age groups have not recommended it in people less than 16 for the Pfizer vaccine or less than 18 for the Moderna vaccine. And so that group right now is really, we're depending on both companies to do further studies. Pfizer began studies of people 12 years and older in September. Moderna began studies of children 12 years and older beginning this December. And we're hoping if we can find correlates of protection in the clinical trials data and in other studies, we might be able to complete the children's studies early by demonstrating the sorts of antibody responses to the vaccines that achieve such great clinical efficacy against symptomatic disease in the adults. This is similar to the logic we used with the human papillomavirus vaccine for the 9 to 15-year-olders. Rather than wait the decades before exposure to HPV and the development of cervical dysplasia, they made the decision based on correlates of protection.
So when's your best guess that we'll have a vaccine that for children and everyone can get vaccinated?
I really hope that in the next 6 to 12 months, we solve these questions regarding correlates of protection and complete those trials with the Pfizer and Moderna vaccine that get us to a point where we can liberalize the use of the vaccine in this age group. Of all of the different risk factors, all of the different demographic issues, in the world of vaccines, age has always been a very tricky thing. A flu vaccine is invisible to a 5-month-older. A 6-month-older needs 2 doses of a flu vaccine to get the kind of response that a 9-year-older would get. But a 9-year-older gets twice the response to a human papilloma vaccine than a 15-year-older and 4 times the response than a 22-year-older. So we see age having a huge effect on vaccine response. And frankly, with the rotavirus vaccine, and particularly with the RotaShield vaccine, we saw safety problems that were based on age, where the older infants actually appeared to have an increased rate of intussusception as compared to younger infants. That's actually led to rules about how we vaccinate against rotavirus currently with our 2 current rotavirus vaccines, where we don't vaccinate people older than 14 weeks with the first dose or older than 8 months of age with any of the doses.
So vaccinating children may become a complicated issue more than it is with the adults.
Yes.
Well, that's interesting to know. I would ask our clinicians, Dr. Fabrizio and Dr. Lisker. I mean, one of the people ask me all the time now is, I'm 22 years old, I'm healthy. Why? I don't know. This is a new vaccine. I know we just spoke about the safety of it, but it's the older people who get it, and we've all said we've seen some younger people do get sick, but the vast majority of younger people. Okay, why should other people take the vaccine? Would you tell younger people to take the vaccine?
I mean, I think if it's available, we all have a responsibility to each other, and I think we need to develop herd immunity. So even if you're a relatively low risk person and you're not going to have access to the vaccine quite early unless you're a healthcare worker or some other type of first responder. But just like it's a responsibility for all of us to mask and protect each other, I think we have a moral obligation to take the vaccine and protect our communities and our loved ones. So I think it's essential that people buy into this and, understand that we are a free society, but with freedom comes responsibility, and we're responsible to each other.
Dr. Lister?
I couldn't have said it better. That was the perfect answer. Thank you.
I guess the question is everyone really wants to know, and Dr. Lister, like what point do you tell people, we could take the mask off, we can go to shul and daven out loud, and the world's going to go back to a normal place? What point do we feel like we're going to be there?
So, I mean, I'm not an epidemiologist. I think the general feeling is that you just need to get close to 70% of the population, as far as I know. So that we're still a long ways off from that. And again, when we take the pediatric population out of it, because until it's safe and approved, that might be another 6 to 12 months. So that's part of the responsibility from those at 16 or 18 and older who it has been approved for, to get as soon as it's available, to get as many people vaccinated as possible. That's the only way we're going to go back to normal life. So,
are we looking at a world? Anyone on the panel want to wager a guess when we can? So children aren't being vaccinated. Can adults start taking off their masks? Are we gonna? When do we see that horizon?
I want to raise something that's important for us to understand with these clinical trials. In these clinical trials for the Pfizer, BioNTech, and Moderna vaccines, the outcome was symptomatic COVID-19 disease. Patients to have the outcome, whether they were randomized to the placebo or to the vaccine, had to have both a symptom plus a positive PCR test. We actually don't know from this early data out of these trials whether it actually stops transmission. There is some evidence with the Pfizer vaccine, because they checked for antibodies in between the first and second dose, that it did seem to prevent asymptomatic infection. But we don't have solid evidence at this point that the vaccine actually prevents spread. That's going to take more data, more study. Now, I would echo Dr. Fabrizia's point. You're getting the vaccine and reducing the health conditions that COVID-19 might cause in you, even if you might recover completely, decreases the burden on the healthcare system that cares for other people. So even if the vaccine turns out not to prevent spread, but only prevents symptomatic disease, it's still an important weapon. Now, I suspect it's going to prevent spread. You had early on said, we haven't been using mRNA to make vaccines, so we don't know. But actually, our measles, mumps, and rubella vaccines, our mRNA vaccines, we've actually just used live attenuated viruses to bring the mRNA into our body to make proteins to make immunity. So we do have some examples of mRNA being very good at generating herd immunity at the rates that Dr. Lister spoke about. But we don't know for sure yet. We have to be very careful that what we know now is the vaccine prevents symptomatic COVID-19 disease. We still need more data to know what it's going to do to spread.
So yeah, I think though that we're all looking forward. Obviously, it's a great step for preventing disease, but I think people are looking forward to that time when we can, go back to some sort of society that we had before. I think probably we've changed forever to some degree, but that's sort of the goal. I think just one more clinical question is actually for Dr. Simon and Dr. Liu. People ask, is this a one-time vaccine? Obviously, there's two shots for these RNA vaccines, but are we looking at other vaccines in the future? Are we going to need booster shots? What do we think based on our biology of the virus?
So far, we've done a lot of research into the longevity of antibody responses upon natural infection, and we found that the antibodies that each of us mounts after infection are very different in levels, but they do last over months. So they don't disappear rapidly as initially thought. So there is hope that the antibody responses that are elicited by the vaccines will last for a substantial amount of time, at least a year or two, because we have observed that upon vaccination, everyone actually makes quite very high antibodies, natural infection, we saw a large variation of levels of antibodies that are produced. But for the vaccines, seem to be inducing very uniformly high immune responses. So gives us hopes that we might need a booster eventually. We might have to develop vaccines that target specific changes in the virus down the line in a couple of years. But for the moment, I think we think that the mRNA vaccines will provide protection for a substantial amount of time.
Yeah. Dr. Liu, I mean, I think one of the things that we all want to know then in that case, I think Dr. Simon's talking about this is, we saw the antibodies, if anyone knows more than you, the antibody response really disappear after just 3 to 6 months.
It's really person to person. There's a lot of variation, but in general, people's immune response lasts for quite some time. And I also would think that it depends upon your exposure level and how your body reacts. It's very individually dependent.
Yeah,
so we are following people now for 10 months after infection since March, and most of the people still have antibodies.
So it's interesting. I think on our detectable end, we've seen is a lot of people, Sean sees this week collecting plasma for the, hyperimmune globulin, and we're watching people's levels, plummet quickly. Haven't seen too many zeros, but there have been there. Certainly the levels decline. I think it's interesting what you said, that the vaccinations are different than the infection. In fact, you're saying your immune response may even be stronger than when you had the virus.
I wanted to bring up a point regarding that. In the Pfizer study, they actually did include people who had previous COVID-19 infections and actually found the vaccines, as compared to placebos, effective even in those people in getting a second symptomatic COVID-19 infection. So while it is less common, even in the trials, we were able to see evidence that the vaccine did something that the natural immunity didn't accomplish. That's not surprising. We have other examples of vaccines that produce far better immunity than wild disease. Tetanus, for example, can produce lockjaw, but it doesn't provide immunity against the next round of lockjaw. And obviously the vaccines provided it much more safely without the complications. Stanley Plotkin repeatedly tells us, be careful about focusing everything on antibodies. Vaccines often have up to 16 correlates of protection, many that are difficult to measure. There may be things that we can't measure that the vaccines are doing that achieve this immunity that the wild form of disease can't. And while the antibodies are very suggestive, and it's the reason why we went after this, this form of vaccine for this disease, there may be other things that the body does in the moments while that spike protein fragment is in the cytoplasm and expressed on those cells that we don't know about and we can't measure, that may be providing protection.
So I think that's you raise a really good point. I think one of the questions that we've been asked a lot is, especially in this community, high rates of infection, people who had already COVID, especially by pace-off time early on, should they get vaccinated? Does their antibody level make a difference?
We are recommending vaccination to all our staff and all our patients, despite previous histories of COVID-19. In fact, we had a long discussion with one of our convalescent plasma donors and our group involved with our convalescent plasma donor unit. She has one of the highest levels of convalescent antibodies against COVID-19. But she's also, because of her work as a nurse, at high risk for COVID-19 exposure. The recommendation from the leaders of our studies and our efforts was, go ahead, get the vaccine. You need that personal immunity that we can guarantee from the trial, rather than the hope that your personal antibodies developed from COVID-19 infection will persist. What we are asking is, of course, if the person had a COVID-19 infection, that they be in the convalescent phase of illness, that they no longer be contagious. Obviously, we have to vaccinate in a way that preserves social distancing, masking, screening for active infection. We don't want to expose people while we vaccinate. For those people who received monoclonal antibody therapy, or convalescent antibody therapy, we are asking for 90 days. And we're encouraging patients who have had an active COVID-19 infection, if they can, to wait 90 days as well, but we don't require it.
Thank you. It's helpful. I think, we're on the hour. We have 30 minutes left. I want to leave 15 minutes, for questions. I want to move on to treatments. I think that, we spoke kind of back and forth a little bit about some of the treatments we talked about briefly on steroids. I want to get to monoclonal antibodies. But I think it's a good opportunity having Dr. DiFabrizio on and Dr. Lisker on to kind of compare some notes on what we've seen. And so, we've had 300 patients at Mount Sinai, as I mentioned, from Orthodox community have come through. Our mortality rate is much, much lower, and we've learned a lot. But, Dr. Rich said we've had a strategy here at Mount Sinai of, come in early, let's get you treated. We have our treatments of remdesivir, antibody therapy. I want to ask before we get to Larry and Geeta, Dr. Lisker, and Dr. DiFabrizio, who should be getting the monoclonal antibodies and when should they be getting them? Dr. Luke? Sorry, I think I lost you for a second. I was going to ask you to comment a little bit about, I think that one of the biggest changes we've had since we've had these since the first wave is treatments and monoclonal antibodies. Who should be getting them?
So the current emergency use authorization of the monoclonal antibodies, the Eli Lilly and the Regeneron antibodies, are specifically for people who are at high risk for severe disease of COVID-19. And those are typically people who are greater than 65 years of age, have diabetes, are immunocompromised in some way, or are greater than 55 years of age and have some sort of hypertension, cardiovascular disease, or some sort of underlying lung disease as well. And that's where we've seen the most benefit for giving the monoclonal antibodies specifically in an outpatient setting to prevent people from developing severe disease.
Yeah, I think it's really important, and you're the one that taught me this, was that in these studies, they were actually given within 3 days of symptom onset. Is that correct?
Yes, it's been shown that the antibody therapies are most effective early or very early on from your onset of symptoms, and that's typically what we aim for at Mount Sinai. Our requirement is usually within 5 days of your onset of symptoms, and that's who we really want to target.
Yeah, because I know the EUA says 10 days and we do 5 days. Dr. Lisker, when do you recommending it? How does it working at Northwell?
So Northwell will give it within 10 days of symptoms. We don't cut it off within 5 days. We refer early as possible. So as soon as we hear about the patients, we will do it. So again, it's anybody over 65, anybody with a BMI greater than 35, anyone with diabetes, chronic kidney disease, an immunocompromised state, which includes, by the way, asthmatics on high-dose asthma and high-dose inhaled corticosteroids. At least for Northwell, we are including those as well. And then, like Dr. Liu said, from 55 to 64, you have a little bit more of for cardiovascular or chronic pulmonary diseases. So we are doing them within 10 days, but obviously the earlier we get to them, better.
Yeah, and I think one of the big pushes that we've had now has been in the hospitals realm, and we're trying to really working with the state and Operation Warp Speed, getting the FQHCs actually on tonight, many of them to start actually giving them in the centers themselves. I know ODA in Williamsburg has about 12 to 15 patients. And so I think, getting it out to the public, knowing that we don't know who's going to get sick. As we said, the $1 million question in COVID is which of those, 45-year-olds are going to get sick and which ones are not. So who should get it? We have to have some sort of scheme, and that's why there is this checkbox that you have to be either older or you have to have some risk factor so we can kind of prioritize. But giving it now locally in these sites, I think will be a game changer as people can have access to it earlier. And I think, as we said, Dr. Liu said, and you agree, Dr. Lisker, the earlier we give these treatments, the more effective they are before they've caused damage to the immune system. So with that said, I think that, anyone who's on this call can contact their FQHC to see if they're giving it or where they can be sent to. And I think that's really an important take-home message. If you're sick and you have risk factors that were mentioned, we really want you to get into treatment early because it may prevent it. We've had really good results looking at this. I think that of the hundreds of patients in our community who've gotten it, we've admitted 3 patients who we would say have been a monoclonal antibody failure. But the vast majority of people who've gotten it have remained either mildly symptomatic or not progressed to hospitalization. So I think it's really been a game changer for us. But with that said, I think we still have a lot of patients who do get sick with don't get monoclonals or realize too late that they've had it, and that's why important. So we've been telling people to come in early as soon as you're hypoxic. Dr. Lisker, I know you can tell us a little about the CROWN program and what you're recommending. When should people come to the hospital?
Certainly can. I will say, just to the prior point, so I had COVID on March 22nd. I still had very active antibodies, and I took the vaccine. So just to give you to confirm the recommendation over there, I can give you a personal standpoint on that. I took it despite my active antibodies. Okay. Yes, we take actually a very different approach. So the CROWN program we developed way back in April, and it's going stronger than we ever could have expected. The idea and the background behind it is that there were many people actually that just did not want to go to the hospital, that were refusing to go to the hospital. Number one. Number two, the hospital systems back in the spring and now once again are overwhelmed and beyond max capacity. And number three, that many of and most, quite frankly, of the treatments that the patients are receiving on the floors really can be done in the patient's homes with the right planning and supervision. And so the CROWN program really was designed to safely and intensively treat patients at home with moderate to severe disease, and then to escalate to hospital level care when necessary, so that even patients who initially were refusing to go to the hospital, if you have been caring for them and achieved their trust, and now you're recommending for them to go, they actually will often listen to it. And so what our program basically is it starts with it's an initial and then very frequent follow-up telehealth visits with a pulmonary and critical care physician. It includes a home RN visit. We will also give the patients a pulse ox if they do not have one. We do home labs. We do home IV fluids based on symptoms or their labs or their physical examinations. I think a lot of the renal failure that we were seeing early on in this disease was based on volume depletion. There's a lot of hyponatremia and a lot of AKI, a lot of renal failure that was based on that. So we do the home IV infusions. We do home labs. If the patients are found to be hypoxic, and so we will start them on home oxygen, and patients who are started on home oxygen are started on on PO, dexamethasone 6 milligrams for 10 days, similar to what they would be in the hospital. And if necessary, actually can be treated with IV dexamethasone as well in the home. Patients who are sick enough to be started on home oxygen, home steroids, home labs, home IV fluids, et cetera, who are receiving hospital-like care, we actually now have approval as well with informed consent, to use off-label IV remdesivir, which we give in the patient's homes with informed consent for patients that would otherwise have met qualification for admission to the hospital. So at this point, for the sick patients at home, we have them at home on oxygen, with nursing in the house, with IV fluids in the house, with labs in the house, with steroids, and with IV remdesivir in the home, all supervised by a pulmonary and critical care physician managing their telehealth. We do in addition to that, we have the protocols for labs. We have a COVID bundle, which is basically, your basic CBC chemistries. It includes a CRP, a ferritin, and a D-dimer, as well as a procalcitonin, which if necessary can be done daily or however often you need it. In our protocol, if your D-dimer is over 600, we start you on prophylaxis NOAC, generally Xarelto. If you cannot afford the Xarelto or it's not covered by your insurance, our health system will provide it for you. And so we basically establish patients' goals of care as well. Are you someone that would never want to go to the hospital? Or if you want to go to the hospital for whatever reason, we establish caregiver or patient instructions as to when you need to call 911 or when you need to let us know. And so generally, if you cannot maintain your oxygen saturation greater than 90% with your oxygen, or if you start to feel short of breath or develop other symptoms that cannot be managed at home, then of course we recommend escalation to the hospital. But otherwise, for the sicker patients, we manage them that way. For the less sick patients, of course, we'll be referring for monoclonal antibodies, which of course, if you really go one direction or another, because our patients that are referred to us are all moderate to high risk. So if you're moderate to high risk and you don't require oxygen and you're early on in your disease, we'll refer you for the monoclonal antibodies. Once you require oxygen, you're no longer eligible for monoclonal antibodies. And so you do the dexamethasone and oxygen route. We get our patients acutely from the communities referred to us by physicians. We get a lot of patients that are treated and released from our emergency rooms who didn't quite meet criteria, or they were on the border, and quite frankly, our hospitals are full. And so if all you need is 2 liters, but you're otherwise stable, we'll get you your oxygen and manage you at home. We also have a group of patients that are discharged from the hospital after COVID, let's say, and they're being discharged on oxygen and they're still complex and they're still at high risk for readmission. So we pick them up at that point and we manage them to prevent readmissions in that case. We've had 850 patients so far. We had 390 in December alone, just to kind of give you the trajectory that it's been going. We've admitted 6% total within 30 days in our acute patients. And we have a 6% readmission rate for these complex patients who are being discharged after COVID, which is remarkable considering the recent publications that really showed if you required home care, your readmission rates were closer to 15%. So this is very intensive therapy at home, and with the goal of keeping you at home, but then with recommending you go to the hospital if you need to go to the hospital.
It sounds like it's a really great program. I mean, it's interesting. I think that, some of the patients that we treat here would be great for a program like this. What we're seeing though is, and Dr. DiFabrizio commented, I mean, we have a ton of patients that end up on high flow. I guess, what's the upper limit of oxygen that you are safely delivering at home?
We will generally tell, again, it depends on your goals of care. Okay, so we will not go above 4 liters. I generally won't go above 3 liters, unless it's, every now and then we will have an older patient who does not absolutely want to go to the hospital and would not want to be intubated, et cetera. And then we'll go up, as high as we can. And we'll also, of course, have a discussion at that point about, hospice should things progress. But generally, we won't go higher than 3 liters. If you can't maintain your oxygen after, greater than 90% at 3 liters, we'll refer you to the hospital unless it's not consistent with your goals of care.
Yeah. I think it's a very good formalized program. Dr. DiFabrizio, what are your,
Well, certainly we have not had the infrastructure to provide that kind of outpatient care. And, I have observation bias because of the fact that I'm an inpatient hospital doctor mainly for this. So, we've seen patients deteriorate pretty rapidly that come into the emergency room on 2 to 4 liters of oxygen and then, progress to requiring, more intensive forms of rescue therapy. So I think, patient selection is obviously key. If people have, severe and unstable diabetes, advanced age, cardiopulmonary disease as a baseline, I would be a little more cautious about those. But if you had a healthier person who's maybe 55 years old and hypertensive with easily controlled diabetes, with a very good support system, I think they have a fabulous program. And I think that seems like it could be the standard for all of us because there are many patients like this that are symptomatic. Our hospital admissions are more frequent in the older populations. And I think if you're over 75 years old and have chronic kidney disease, heart failure, advanced COPD, or a malignancy, particularly hematologic malignancies, which we see a lot of here, those are patients that are extremely high risk. And I think you could, with good screening, select patients that could be treated at home. And I think you certainly need that kind of close and scrupulous monitoring. We have an outpatient home monitoring program for people who are discharged, where they go home with a pulse oximeter, and then they have follow-up. But we have not initiated the kind of program that they're doing at Northwell. And, I would be very happy to see and learn more about it.
Yeah, I mean, I think I do agree that there's a selection bias here to some degree. Those who end up in the hospital, I think Dr. Rich said it at first, is if you get into any kind of treatment early and you get the appropriate treatments, whether it be low dose oxygen, whether it be, steroids, blood thinners, if you're at that moderate risk and you initiate treatment early, you get that chance to observe that curve. I think what we're seeing, right, is that, it takes about 24 to 48 hours to judge the trajectory of a patient, right, when they come into the hospital. So I think, what we see in the hospital admissions often are people who have been sick for, 7 to 10 days already.
Right, absolutely. And I think, there's a distinct phenotype for the early patients where they're kind of in a viremic phase. And at day 10 to 14, people who've been sick for that long may already have antibodies and not are candidates for either monoclonal antibody or for plasma, and are in an inflammatory phase, which is really particularly dangerous. So, those late cases are the ones that concern me the most, and I think give us the most trouble clinically. And they may not really be good candidates for even remdesivir at this point. I was actually interested in getting feedback from Dr. Liu with respect to whether we would actually ever get to a point where we're measuring viral loads, and just if you could comment about the cycle time. Whether this is an important thing we should be checking on every patient to make decisions with respect to using either monoclonal antibody, plasma, or remdesivir. If I may ask a question of another panelist.
Yeah, I know that we frequently do check the cycle threshold to see whether it's a higher number cycle threshold, meaning it takes more cycles for the PCR machine to actually detect virus, suggesting that the viral load, that the virus is actually viral remnants and there isn't much active virus occurring in the person. We sometimes use that as an indirect indicator to suggest that it's past this quote unquote viremic phase, and that sometimes the antiviral therapies may be less of use, and that comes in play sometimes when we make decisions about remdesivir as well as plasma therapies and such. But it has not become there's very little standard or evidence-based guidelines to suggest when to change management because of that.
Yeah, I mean, clinically, I would say that those patients who were the late cases, in our experience, have had, very low viral loads. So, and they're quite sick, so people can be actually sick with the typical, viral syndrome early on in the course. So in the first few days, high fevers, body aches, myalgia, some cough, coryza, typical flu syndrome. And then, later on, after 10 to 14 days, if they've kind of gotten through that phase, we see what I would call the inflammatory phase, where there can be a significant lung and multi-organ injury. And that is a very, frightening time for the patients and really challenging. So I think, that's why I've always been in favor of at least getting the patients evaluated. And I'm intrigued at, how well they're doing at Northwell with respect to, catching these cases early. Because I think, initiating these therapies early on can make a big difference. But, if we've seen the patients after they've been home sick for 2 weeks, and now they're coming in, we've already selected patients who are going to do more poorly.
Yeah, I have to say, we're not, just to be fair, not all our patients are we catching early. We have a lot of old, sick, multi-comorbid patients who we're catching at day 7 to 10. We do, in fact, some of them obviously do end up getting admitted, but this, idea of you only have those 2 hours for them to crap out from 2 liters to needing intubation, it just hasn't really panned out. We've sent patients to the hospital. We haven't lost anybody. We have not, and we've had a very sick population. And when they start to have increasing oxygen requirements, and it happens infrequently, like I said, we've admitted 6% of our patients, but they make it to the hospital and then they're put on high flow. We have not sent anybody who we've been following, and 1 minute they were on 2 liters and the next minute they were in the ER, intubated. Again, don't forget, we've been following their inflammatory markers. We've been doing visits with them every day. And so these are not a well-selected group of patients at all. These are 89-year-old. I have I cared for a patient through Shabbos. Actually, we ordered oxygen. It's an 89-year-old with heart failure who, with a bad diabetic. We also involve the endocrine team who will then follow up with the patient on a daily basis and monitor their sugars and adjust insulin as necessary while they're on dexamethasone. Where we have patients that we're giving IV fluids and balancing their pro-BNP levels together with their, holding their Lasix and giving them IV fluids and giving them their oxygen. And so, it's a balancing act, and obviously some of them end up needing to be hospitalized, but I think it's fewer than we would think. And I totally get the bias because I myself, before this was mostly in the hospital, but it is definitely a balancing act. That's what I have to say. But we're in no way selecting patients early or healthy.
That's good. It's really good for us to learn from each other, right? So I think it's important to find out what is different. I mean, we have patients that, I agree with you, we don't see patients usually go from 2 liters to intubation, but we do have this window where we'll watch people for a day or two and they'll be getting the pulse dose steroids or IV dex, and they'll still progress. And again, it's very few. I mean, we've had 300 of the patients from our community come in. We've had about 10 deaths. We've had people come in at day 14 who progressed. We have people coming at day 1 or 2 that have progressed. So it's really interesting to kind of put all that data together and understand that. I think what's key, we all seem to agree on this, is that if you're sick, get whatever treatments are available at your current stage, whether that be monoclonal antibodies early on, or as soon as you hit this inflammatory stage, to get treated with the steroids and blood thinners, which I think have been a game changer. Patients who come in, if you're sick and you don't get any treatment, it's a little bit too late for whether you be in our program, your program, to really get you through. I think it's just we kind of temporize the inflammatory phase with the blood thinners and the steroids, and we wait for your body to wait it out. I do want to bring up one last topic, and I'm going to go to the questions. Is, in the beginning of the pandemic, the hot word was hydroxychloroquine. Everybody was taking it, and we talked about it, and they swore by it, and people think that that's what cured them. You know what? Studies didn't pan out, and we still say, Dr. DeVries said, maybe it did some inflammation. Now people are coming to me every day, ivermectin. Does anyone have any idea why ivermectin would work, or if they think it's a therapy that would help reduce infection or disease?
I looked this up a little bit. Apparently, ivermectin blocks the important system, which also works on basically your host cellular mechanisms that may interrupt viral replication, but it's been specifically found in vitro setting, meaning in the laboratory setting, when you put ivermectin into a petri dish and then you try to grow virus, the ivermectin may prevent the virus from growing. However, they calculated that concentration that you need to put that you put in a petri dish to put into a person is about 100 times the standard dose that you should put in people. And so there's no there is no suggestion that you can reach those levels inside of a person. And currently it is not recommended to use ivermectin for people for the treatment of COVID-19 per the CDC guidelines. And that is not recommended. There's no strong science to support that. There is a retrospective observational study that looked at ivermectin in, I believe, Florida. And the data is not very clear, but it suggests that there may be a more mortality benefit, but the current guidelines suggest not to use ivermectin.
Okay. Thank you,
ivermectin is typically an anti-parasitic agent. Yeah.
So you're not taking ivermectin.
I was just going to say that ivermectin is an example of passion ahead of science. And, we have a colleague in the pulmonary community who has been advocating this with a group of other, quite experienced and respected pulmonologists, and had given some, testimony at a Senate hearing. And he's a very passionate, he wanted us to be able to have some other maybe NIH-funded study or some review of ivermectin. And I think, one issue that was raised, which is similar to the Plaquenil issue, is whether generic drugs, which are not pharmaceutically, costly, could be studied for a condition like this. And, as you said, there's science that kind of helps you design a study, and then there has to be also resources provided to do those kinds of studies. But the passion is way ahead of the science here, and I think right now that's not part of our armamentarium to use ivermectin. But there are people out there that are believers, just like there were believers for Plaquenil. My own personal view of Plaquenil is that it has anti-inflammatory properties, and given all by itself, it didn't have a major impact. But there were people who actually developed some symptomatic relief and had a decrease in biomarkers. It certainly wasn't potent enough to alter the course of the illness, and that's been borne out in a lot of studies.
Well, I mean, every one of the topics that we hit tonight could probably be its own, 2-hour conversation. So we try to do these evenings of education, hitting a little bit on everything. So we can't, we'll never get through all the topics. But I wanted to open up, for a few minutes just to anyone on the panel from the FQHCs, any specific questions. I want to be mindful of the time that, 5 to 10 minutes of questions. So I don't know if you want to invite anyone else in who's hosting the chat. I think was one question here that Dr. Jacobson had answered about how long do we wait after COVID to get vaccinated. Thank you, Dr. Jacobson. You mentioned how long?
Well, for a person at a COVID-19 infection without treatment of monoclonal antibodies or convalescent antibodies, as soon as they are convalescent and no longer contagious, they could get the vaccine. We would ask, given the rarity, the restrictions, the limitations of the vaccine availability, they consider waiting 90 days.
Dr. Kamenetsky, you had a question as well? I think someone has to unmute you.
Quick question. Is anybody using the IL-6 inhibitors anymore in the inflammatory phase? And also on the same subject, in terms of monoclonal antibodies, I know that for people who are not as sick, the Eli Lilly drug, I'm not going to try to pronounce it, we're using for the people who are not as sick but have risk factors prior to admission. But what about later on, if people didn't get it? Is there any role for the monoclonal antibody from Regeneron or another one once they're in the inflammatory phase or not doing well later in hospitalization?
Dr. Liu?
So there have been studies looking at sarilumab and tocilizumab, the IL-6 inhibitors, and they have not been shown to be effective. And the inpatient monoclonal antibody studies looking at hospitalized patients have not been shown to be effective. That's why the emergency use authorization is primarily targeting towards ambulatory patients. So the casirivimab and the Divimab or the bamlanivimab, they're strictly for ambulatory patients.
Yeah, and I think, as Dr. Liu's not talking about now, is that we at Mount Sinai, have the HIG trial. We're basically taking super concentrated plasma, which has the monoclonals are 1 or 2 antibodies to a specific target on the virus. We've taken the convalescent plasma and concentrated it. So actually an ongoing study how that will help our sick patients. So those are the treatment options once you're sick, is the plasma or HIG, but beforehand it's the monoclonals.
Yeah.
You had one other question before? I think there were some other questions that are coming in now on the chat. A lot of patients about post-COVID syndromes. I think that it's a very difficult area, but there's a certain percentage of patients, that had COVID and continue to have symptoms for months and months later. I know Mount Sinai, we have a post-COVID center at Union Square. We are on a cardiac post-COVID center at Mount Sinai West. a lot of kind of funny inflammatory things that we haven't fully defined yet. I think each individual question should be addressed to their specific doctor or one of these post-COVID clinics. But often we treat with short courses of steroids to try to, and do other testing for inflammatory conditions, but really no specific guidelines yet. I don't know, Dr. Lisker, does Northwell have a post-COVID center?
So Northwell has the CARES program where we tailor, basically we tailor the specialist that you're going to see based on the symptom that you have. So if you call in for a referral and you're having persistent respiratory or breathing issues, you'll probably get referred to pulmonary and cardiology. If you're having neurologic issues, et cetera, you'll be referred to whoever it is that you have, all with the agreement that we're all kind of admitting that we're making it up as we go along based on best practice and our best opinions of steroids, et cetera. I know in the post-pulmonary issue, if you have persistent findings of, persistent CAT scan abnormalities or pulmonary function test abnormalities at 8 weeks or at 12 weeks, do we give you another course of steroids? At some point, do we give you an antifibrotic agent? And this is all currently being studied all around the world, and really just expert opinion at this point rather than evidence-based medicine.
Would you vaccinate these people? If someone had a post-COVID syndrome, they had COVID in March, would you vaccinate them now?
I mean, I would. I don't see any reason not to. But see what Dr. Jacobson has to say.
I would agree with you, Gita. I think that these patients need protection against a second occurrence of COVID-19 infection that might greatly worsen their syndrome. And I don't believe that these are being generated by the same factors that the vaccine would create. We saw no safety signals that would suggest this similar sort of immune problem.
Thank you.
Okay. A lot of questions, but it's mindful of the hour. I think, we'll probably be back in about 2 weeks for another session. Have on with my partner, Dr. Schatzkis as well, and another panel. So thank you everyone on the panel for their time, and thank you everyone for participating, and have a good night.
Thank you for having us.
Thank you very much.